present point of time. We have to listen what Nicholas is going to speak on. So now I call Dr. Sandeep Vaishya to give his talk. Sandeep, are you there?
Yeah, so I'll just share my screen.
Yeah, please, Sandeep.
I'm disabled from sharing the screen.
No, I think, Yahya?
It says that host disabled participant screen sharing.
Okay, we are.
You are the co-host.
Yeah, but it is not allowing me.
Look at.
Yeah, you know you can do it.
Yes, you can.
Yeah, okay.
Yeah, you got it.
Yeah, I think so. Okay, can you see my screen?
Yes.
Let me run the slide. It is not going into the play mode. Full screen.
Yeah.
Can you see my full screen? It is not going in full screen mode.
Yeah. You can switch on the play.
Yeah, I switched on the play, but it is the full screen is on.
Or play slideshow.
Play slideshow. Yeah, okay, it's working now. Okay, so I will be talking on the risk factors for the recurrence in the lumbar disc herniation. So, as we all know, after a disc surgery, the worry is about the recurrence, and whatever you do, you will still see some recurrences. So, what are the risk factors so that you can explain to the patients preoperatively and you are well aware of it? So, recurrent disc herniation has been defined as the disc herniation at the same level after a previous discectomy, regardless of the ipsilateral or contralateral herniation, with a pain-free interval greater than 6 months. Again, this time frame is controversial, and I'll show you an example. So this is a patient who was operated in June 2023 in another hospital. He was perfectly all right for 2 months. He was diabetic, but 2 months later, his symptom recurred. That was in September, and by October, he was worse. And you see this, the first MRI is of June 23 when he was operated. And you can, in the lower image, in the axial section, you can see the disc herniation. While in the latter one, you see that was in October, and the disc herniation seemed worse than before. So, and he developed disc recurrence just 2 months after the initial surgery. So again, the time factor is not sacrosanct. I personally believe that any patient who had a pain-free interval and at least for a few weeks, and later on has significant symptoms, I will call that recurrence. So the incidence in traditional open approach has been reported from 3% to 19%, and in minimally invasive approaches from 3.5 to 10.5%. I personally think that the approach doesn't really matter. It is the whether it is open approach or minimally invasive approach. It is the way a surgeon approaches the disc surgery and the other factors which I'll be discussing, which can lead to recurrence. And the most common level is L4-5 level, because anyway the discs are most common at this level because of the increased mobility. So among the risk factors, in the clinical risk factors, the age, gender, body mass index have been implicated. And in the lifestyle and comorbidities, smoking, diabetes, lifting heavy weight, and the occupational work that has been implicated in the recurrence. And in the radiological factors, the level of herniation, the type of disc herniation, the degree of disc degeneration, the disc height or disc height ratio, modic changes, and the sagittal range of motion all have been implicated as risk factor for recurrence. And the surgical annular defect and extent of discectomy, but that is the next talk, so I won't dwell on that. So coming to age, so according to this publication by Chinese authors, more than 50 years age was a very strong risk factor for the development of recurrent lumbar disc herniation. So they studied 111 patients operated with a microendoscopic approach, and it was a retrospective study. While there were many other studies where they could not find any statistical significance between the age and the recurrence. While there were these other two studies which suggested that less than 40 years was associated with high risk of recurrence. So there has been no unanimity on the age as far as the literature is concerned. And in my personal experience, I have seen that the younger patients have a higher risk of recurrence. I don't remember any patient above 50 having a recurrence. So it was mostly all the younger patients. Now, sex, again, a risk of recurrence was significantly associated with male sex. So these are two studies which suggested that males had a much higher risk of recurrence as compared to females. And similar has been my experience. Like, if I could recall, I remember only 2 females in last 5 to 6 years who had recurrence, while I must have operated at least 20 males during this period for recurrence. And now, body mass index, obesity has been reported as a strong predictor. BMI above 30 was 12 times more likely to sustain recurrence of the herniated nucleus, and 30 times more likely to require reoperation compared with non-obese individuals. So these were multiple studies which suggested that. While there was another study by Rin et al., they found that obesity versus non-obesity had similar rates of recurrence, that is 7 and 6%. So they did not have any significant influence. So we are also doing a study on the BMI versus risk of recurrence. So I hope in the next couple of years our data will be completed. Now, smoking was significantly more common in those patients who had recurrent disc herniation. And the possible mechanisms were, because the discs are the biggest avascular structures in the body and the nutrition is supported by diffusion, the smoking contracts the capillary vessels and affects the cellular multiplication and metabolism. And in that way, it delays the healing process of the tissue. Similarly, the annulus fibrosis and PLL after surgery recovered in normal physiological conditions, but in smokers, the toxins degenerated by smoke delay these normal conditions. So the healing is poor. So nicotine affects the annulus nutrition and oxygenation. So these all may lead to poor healing and lead to recurrence. Apart from these cellular and molecular changes, repetitive cough in chronic smokers increases intradiscal pressure, and it may also contribute to the recurrent lumbar disc herniation. Now, coming to diabetes, which has been found to have a strong association, and Robinson et al. Compared the pathological specimen of discarded disc from operations. And they compared the intervertebral disc between the non-diabetic and diabetic patients. So they found that in diabetic patients, there was lower glycosylation rate, there was lower number of sugar side chains per core protein, there was slight increase in the chain length of chondroitin sulfate, there was decreased amount of keratin sulfate glycosaminoglycan. Frankly, I don't understand what the heck all this means, but I'm just reading it out. This was mentioned in the paper. And these changes lead to increased susceptibility to the disc prolapse. Again, Carnegie reported that in diabetic subjects, the annulus fibrosis healing may be poor, and it may not be as steady as non-diabetic subjects. So again, all these factors may lead to recurrence of the herniation. So this was another paper which suggests, this is not related to recurrence, but this was a paper which suggested there was a strong association of type 2 diabetes with degenerative lumbar spine disorders. And in that ratio, the recurrence rates are also higher in these patients. Now, as far as occupation is concerned, there were these 2 Japanese papers which mentioned that the lifting weights as part of professional work was significantly associated with recurrence. And this another Japanese paper suggested that surgeons should advise their patients to limit hard laborious work to prevent the recurrence of the disc prolapse. While another paper by Meredith et al. Showed that the manual laborers did not have a similar high risk of recurrence as compared to those who were not involved in manual labor. So again, there is a discrepancy, and there is no consensus on this, whether the hard work will increase the risk or not. Among the radiological criteria, the degree of degeneration of herniated disc has been associated with recurrence. Furman grading, this grading is shown here as grade 5, but the modified Furman grading has 8 types. Grade 1 and 2 are minor degenerative changes, while grade 7 and 8 are severe degenerative changes. So this paper by Kim et al. Suggested that in grade 1, and that is in minor degeneration, and in grade 7 and 8, that is in very severe degeneration, the risk was much less. While patients with moderate degeneration, that is group 3, 4, 5, and 6, had a much higher risk of recurrent disc herniation. And again, the main factor involved here was because these patients had a preserved disc height. So now coming to the disc height index, modic changes, sagittal range of motion, which all have been implicated in the high risk of recurrence. So disc height, the patient with recurrent disc height, recurrent disc had a higher preoperative disc height the mean was 19 millimeters as compared to those without recurrence who had 15 millimeter disc height. So the p value was less than 0.001 for the disc height ratio. And this paper was by Yaman et al., but unfortunately not Onur, it was some other Yaman. Now, disc height index is measured by the height of the involved disc in the center, which is divided by the height of the vertebral body in the center, the superior vertebral body in the center. And this ratio is taken as, if it is more than 0.15 is taken as the cutoff, and if it is more than 0.15, the risk of recurrence was very high. Now, in sagittal range of motion, it was measured radiographically as the sagittal angle between the superior and inferior end plates of the respective vertebral bodies between the extension and flexion positions. So the higher the range of motion, the higher was the risk of recurrence. So they, Kim et al. Took 10 degrees as cutoff point. And when they took 10 degrees as cutoff point, 26.5% patients with more than 10 degrees had a risk of had reoperation, as compared to only 4.1% in the patients who had less than 10% motion. So this difference is attributed to the association between increase in flexion and extension leads to disc instability, and this causes more load on the intervertebral disc. Now, motic changes also have been implicated in the recurrence of the disc herniation. And so all these studies suggested that motic changes were statistically involved. And this study by Bellick et al. Suggested that type 1 changes were found to be significantly correlated with the recurrence rate of 62% as compared with 12.3% in non-recurrence group. Now, extent of disc herniation. So disc can be protruded, extruded, sequestered, or migrated. And amongst all these, the extruded and sequestered discs had the highest rate of recurrence. So, and the p-value was less than 0.05. And anyway, it is understandable that in extruded fragments, sometimes there can be missed also, or sometimes because the ligament is also not intact, the risk of recurrence will be higher. I think, and these are the topics for the next talk. So these are surgical, so I'll just skip these. So to conclude, the major risk factor for recurrence of the disc prolapse are disc height index, motic changes, extruded or a sequestered disc, diabetes and smoking, and sagittal range of motion. And surgeons should be aware of these risk factors so that the patient can be counseled appropriately. Thank you.
Thank you, Sandeep, and for summarizing very nicely those important points that has to be considered when we think when it can recur. So this will give us some idea before we operate primarily on these cases. Particularly, the point which you made on smoking looks very significant, and also the younger generation patients have recurred more in your personal experience. That's what you
Younger
said.
and male.
Yes, younger and male. Yeah, that's very important, and that's very interesting. But actually, it is true. Maybe it is because of the stress and strain and the more activities the younger guys are doing in our area. Now, we